Esteemed members, good evening, and thank you so much for joining us today. If you can hear me, just send a message in the chat and let us know which branch of PSK you're joining us from. All right, I see some feedback. Thank you so much. Caleb from Turkana, Dr. Monica from Kiambu, Sylvester from North Rift, Ruth from Busia, David Mullah from Nairobi. Welcome. Thank you so much for the feedback and thank you for joining. So as we wait for the session to begin, I'd like to encourage you to just go to the PPB portal and subscribe to the event. You can use the keyword Lifesaving and you should be able to find the event easily on the PPB portal. Santeni, for those who are joining and for those who are letting us know where they're joining us from. Right, good evening once again, and thank you for joining us today. We have a webinar that is going to be focusing on adoption and scale up of life-saving maternal health innovations in the era of devolution. And we'll be getting some county experiences on procurement of heat stable carbetocin and calibrated drips. And with us today, we have our speakers, pharmacists who are working in the counties, and also a team of partners who will also be supporting as moderators for this session. And once again, if you've not subscribed, I'd like to encourage you to do so. This will enable us to send you the CPD points on time. So ensure that you just subscribe at least by the end of this session so that we can organize for that. And a few ground rules, you'll be muted during the entire course of this session. So if you have any questions, I'd like to encourage you to use the Q&A tab, which is at the bottom of your window, and the questions will be addressed by the presenters at the end of the session. And kindly note, this session is being recorded and it will be made available on PSK's YouTube page. So at this point, I'd like to welcome the moderator for today's session, Dr. Ruth Wamai, who's going to be moderating the session. Dr. Ruth, if you can hear me.
Thank you, Dr. Hezron. So my name is Dr. Ruth Wamai. I'm an obstetrician gynecologist. I'll be moderating today's session. I'd like to welcome everyone to today's webinar. Our webinar is on the adoption and scale up of life-saving maternal health innovations, especially in the era of devolution. This week, we have been hashtagging DevCon 2025. It has been the week where devolution in Kenya has been discussed in Homa Bay County, and we hope to be sharing our experiences here in terms of maternal health. I'd like to just introduce to you Michael Muthamia, my co-moderator. He's also a senior regional program advisor at JPIGO, and also Samuel Kibonge, who's driving commodity access at PATH under the Ampli PPHI program. So without further ado, I'd like to introduce our first speaker of the night, who will be Dr. Eric Chomba, who is a county pharmacist in Makueni, and he'll be sharing his experiences with MNH in the county. Dr. Chomba? Sorry. I think, Michael, can you hear me?
Yes, I can hear you, Dr.
Yes,
Wamai.
sorry.
So thank you very much. Dr. Ezra, we can share the screen again. Yeah, so I'm sure Ampli PPHI project is not new to you. I know we've collaborated on very many occasions during your congresses and in other events. If you can go to the next slide, please. So this is a project that is seeking to catalyze early adoption of new innovations. We know that sometimes when new innovations come up and there are no efforts to accelerate their scale up, it takes years to actually reach where they're supposed to reach. And therefore, this project is really here to catalyze that early adoption of life-saving innovations. Our focus has been stable carbetocin for PPH prevention, calibrated drips for objective blood loss measurement, tranexamic acid as part of the WHO first response bundle under the motive bundle, and then advanced distribution of MISO for PPH prevention. This is a project that is funded by United, and it's in many other countries, 5 other countries. Next slide. Our implementation has been both national and in Makueni County. And in Makueni County, we've been focusing in 36 public health facilities, which account for 92% of the births there. And our approach is providing quality assured medicines, such as itzebocobetocin for PPH prevention. And also, we've been working on introduction of the motive bundle, which has been shown to decrease death and surgery from excessive bleeding after birth by 60%, which is a groundbreaking research under the emotive trial. And we've been collecting data using supplementary tools and also the KHIS. We've seen great leadership from the county, as you'll get to hear from Dr. Chomba. Next. Yeah, so one of the things that we did early was supporting the ministry to develop a confession report for both PPH and other maternal health products. And in this photo, we were handing the confession report to the governor. So there's value in having the county leadership take ownership of these innovations, and that is how they're able to allocate resources and advocate for their implementation. Next slide. Yeah, so we've been implementing a package of intervention. It's not only introduction of drugs, but really training, creating awareness, both at the facility and at the community, and also implementing quality improvement measures, such as MPDSR, pharmacovigilance, among others. We've also been working very hard with other partners through smart advocacy to make sure that there is policy change to allow introduction of these interventions, not only in Makueni, but nationally. Next slide. Yeah, so as a project and together with other collaborators, we've seen the updating of the national guidelines to allow use of these products and interventions across the country. We've had the quantification report for health products and technologies, which has been used for advocacy. For example, that led to the procurement of 360,000 doses of itzebocobetocin by KEMSA. We've had donor roundtable meetings, which have led to great support for the country, training of 165 national trainers and over 500 mentors at the county level who are implementing emotive, which is not only focusing on PPH, but other obstetrical emergencies. And then one major win was the reduction of price of itzebocobetocin from 2,700 to 95 at KEMSA, and now 92 at MEDS, which is a big, big thing. And we are here to celebrate. I know when we had this conversation a couple of years back, we were envisioning a situation where each and every county will purchase itzebocobetocin, and we are happy to report that all the 47 counties have now procured itzebo for PPH prevention. And that is why we have a team of counties here to share their early experiences. Next slide. Yeah, so we've also seen the medicine being procured by MEDS, and it's available there. And to coordinate efforts at the national level, we've supported the national team and the Ministry of Health to develop a national costed and implementation plan and a rollout plan, which has been used for resource mobilization. And through collaboration with Fairing and other partners, we've seen a lot of awareness creation across all the counties, and therefore leading to appropriate use. The other innovation was around calibrated drips, which is a great innovation. It has been introduced in the country. We have a local manufacturer here. We're supplying the entire region. And this is also a life-saving intervention, as you get to hear from Dr. Chomba. Next slide. So we've also not focused only in Kenya. We shared our experiences with Uganda, and they're making also great progress, training their regional hospitals, procuring the medicine as well, and also developing a costed implementation plan. In Makueni County, we've seen 99% of the women there receive itztebukabetosin, and 100% of the PPH cases that we get there have been getting the motive bundle, making a huge difference. Next slide, please. Yeah, so a calibrated drip is a new product because we've been using matchometer, using our eyes to estimate the amount of blood that a client is losing, which has been found to be a very poor way of estimating blood loss, missing almost 50% of the PPH cases. So if you miss 50% of the PPH cases, it means that you only treat half of the PPH cases. So I kindly request you to advocate and consider procurement of calibrated drips for objective blood loss measurement. But a drip alone cannot solve out the issue. It should be coupled with appropriate training so that once PPH is detected, then the motive bundle is triggered immediately within 15 minutes to address the issue. Yeah, in Makueni County, in our 36 supported facilities, we've seen a consistent increase in utilization of drips, so which means they are acceptable and it's feasible to introduce them. We are now at 91% of all births that are taking place in those 36 supported facilities that are using calibrated drips. And then finally, we've seen a big win, a big story. I'm sure you've heard of it from Makueni County. We go to the next slide, where we've seen a serious reduction in maternal mortality. In 2022, all maternal mortalities were 23, and they came down to 11 in 2023 and 11 in 2024. These are all maternal deaths. But now when you focus on maternal deaths due to PPH, 2022, there were 12, 0 in 2023, and only 1 in a private facility in 2024. And in 2025, I know you hear from Dr. Chomba, we've only seen 2, which is a huge change. And this story has actually been shared within the World Health Assembly that happened in May this year. And this is a great opportunity to scale up something that works. A reduction of maternal mortality is so difficult. And if you get an innovation that is giving promise, please run with it. And that is why we're here to share experiences and see how best we can collaborate to scale up these innovations that are making a difference. Thank you. Back to you, moderator.
Thank you so much, Michael, for that introduction to Ampli. I think we must appreciate the work that the project has been doing, and that the support that we've also received a lot from the pharmacists and even the pharmaceutical technologists who have helped us in creating awareness in terms of procurement of this product. So I'd like just to let the pharmacists now present their experiences with the introduction of the products into their counties. Makueni County was actually the pilot county for the project, but the rest of the counties will be presenting have actually been adopting this in real life, and they'll be explaining to us what their experience has been. So we'll have Dr. Eric Chomba, who's a county pharmacist of Makueni, and then Dr. Josephine Guri, a clinical pharmacist, and she's a sub-county pharmacist in Dagoretti South, and Dr. Asmahani Ndaisi, who is, she has a master's in pharmaceutical science, and she's a sub-county pharmacist in Kajiado North. So let us hear from them. Dr. Chomba, karibu.
Thank you, Dr. Amai, and thank you to Michael for the introduction to the webinar. I'm Dr. Chomba, County Pharmacist Makueni, I'll take you through our experience with stable carbetocin and also calibrated drips. Next slide. So as it's been elaborated by Michael, we've been implementing a project in Makueni, and JPEGO has donated stable carbetocin for the 36 facilities, and this covers 92% of births. We started using stable carbetocin in January of 2023, and the trainings were done with support from JPEGO and the project. But additionally, the county government took up the other facilities. We have a total of 242 facilities in Makueni. So we also procured an additional 2,000 ampoules of stable carbetocin from KEMSA to cover the other 10% or so of births. This was a concerted effort after getting buy-in from the leadership, as high as the governor. I think you saw him in one of the photos presented by Michael. And we extended that goodwill to procure calibrated drips. Currently, they're not available in terms of meds, but we were able to do a request for quotations, floated them, and a local manufacturer actually won the tender. And we were able to procure 11,000 single-use pouches, 250 mats. So this is a detachable calibrated drip, and we'll be speaking about the experience on that a bit later. But we also procured other innovations such as the NASG and the free flow UPT from meds. Next slide. So what has this investment translated to? Michael presented part of this data of PPH in Makueni. So in the year 2022, before the project, we had 12 maternal deaths attributable to PPH in Makueni County in public facilities. This reduced to 0 in 2023. I mentioned that we began the project in 2023. We had 1 maternal death attributable to PPH in 2024. And this year we've had 1 in GOK facilities and 1 in private facilities. So this shows a significant reduction in PPH mortalities. Actually, our cashews in the maternities have nicknamed stable carbetocin as Kausha because there is less blood loss in the labor rooms. So they have noticed that the cleaning is less at that point. But I would like to have a disclaimer at this point that stable carbetocin is not a silver bullet. The other interventions, Michael mentioned the bundle. He also mentioned the training, so that you use stable carbetocin for prevention of PPH and not treatment. So that is still necessary, but we had advocacy, we've had training through the project, and our governor, His Excellency Tulaki Lonzo, was a silly crowned PPH champion. He actually attended the Ops Guys conference just to understand more about PPH and lobby and advocate for PPH funding and reduction of maternal deaths at COG. And that's how the Makueni story was featured in the World Health Assembly this year in May. Next slide. So a few things to point out from our story. So pharmacovigilance we needs a bit more strengthening so that we document any medication errors, any adverse events. Any wrong indication needs to be communicated and not to just castigate the staff who did a medication error, but as a learning experience. That's something that we need to strengthen. And then another point to ponder is we've had PPH maternal mortalities in private facilities. So they need to be involved in the implementation of these innovations. They need to be able to access some of these products. even at the price, the access prices, it's something to consider as a nation, so that the mothers going to private facilities also benefit from these innovations. Then drip specifications and quantification. As I indicated, we procured the detachable one. And there's one that is a single drape. The pouch and the mat comes as a single-use drape. And from feedback from the facilities, the midwives actually prefer that. And then the quantification, we initially quantified that we only need one per mother, but we came to learn we actually need two per mother, so that the mother uses one in the labor room, and then when she goes to the recovery room or the recovery bed, she also needs a drape, because there is some blood loss that happens when you go to the recovery bed. So that's something that we've learned. Then some of the next steps, I feel we haven't shared more of these stories. Maybe do some more surveys on this, and just share out some of the innovations that are happening in the counties. I know KEMSA is intending to stock calibrated drapes, NASG and UBT. They say probably from next month, so let's wait for that. And that makes access possible for more counties. And currently, KEMSA, I think the stocks of heat-stable carbetocin is around 40,000 ampules. And they have plans to procure more, because all counties basically have gone ahead and procured heat-stable carbetocin. Tracking of the heat-stable carbetocin, it's not in the HBT tracer tool, so probably its inclusion will help just the tracing of the drug, and ensuring that all facilities and all births and all mothers have access to heat-stable carbetocin. Next slide. Yes, so this is our governor during the launch of the heat-stable carbetocin, with the project director of Ampli PPHI. And next to it is a sample of the detachable calibrated drape that we procured, just for you to appreciate. Thank you so much.
Thank you so much, Dr. Chomba. Dr. Chomba is the county pharmacist in Makueni County, which was the pilot county for Ampli PPHI. At some point, I almost thought you have become a gynecologist. You know how much blood we are measuring in maternity. But thank you so much for pioneering and actually leading the country. And I think lessons have been learned from Makueni, and other counties have really adopted the innovations also. We actually have 47 counties covered by the product. So I'd like to introduce Dr. Josephine Guri next. She's a sub-county pharmacist in Dagoretti South.
Hello and good evening, everyone. Thank you so much, Dr. Ruth Wamai, for the introduction. I'm doing this presentation on behalf of Dr. Nora Maura, who is the county pharmacist. So I hope she's online when it comes to question and answer. But nevertheless, I will proceed on with the presentation. You can go to the next slide. So Nairobi County has just recently procured heat-stable carbetocin. I think we've just, probably this is the second quarter of us having them in stock. And we've managed to stock up all our public facilities through KEMSA, using county funds that were lobbied for by the county pharmacist. So Nairobi has actually over 100 public health facilities. They could be, I think, 120 if I'm not wrong. And we procured heat-stable carbetocin for all of them. Then the good thing is that, as it had been mentioned earlier, we bought this at 95 shillings per ampule, and that means we were able to buy large quantities, as opposed to having, I mean, if you'd have had to buy it at 2,700 at the market price, I don't think we'd have been able to stock up the product in all our facilities. So of course, this has increased access, and has made it possible for us to bring it to the facilities at large quantities. And then the fact that it does not require refrigeration has made it possible for us to take it to the lowest level, including the level 2s that some of them do not have refrigerators. Next slide, please. Then some of the strategies that we've been using, of course, not only do we use heat-stable carbetocin to prevent PPH, but we have some other innovative strategies that we've been adopting, including mentorship, because the first thing we did before we stocked up our facilities with heat-stable carbetocin was do a number of CMEs. We trained so many healthcare workers, both online and physically, on how to use heat-stable carbetocin. And of course, also we included so many pharmacy personnel, because we noticed that we normally procure some of these commodities, but most of us do not really know how to utilize them or how to use them, or we are not confident. And of course, that made the utilization of the product go higher as we stocked it up. Then we've been having drills, facility-based drills on PPH and what to do, which involves as many healthcare workers as possible. And then, of course, Nairobi County is also known for their online CMEs that we do almost every week. And then we also include most of our private health care facilities, our NMOC trainings. And then we also have been advocating for public health facilities to budget for staff training using the SHA money. And the other thing that we've been able to do recently, which is a big win, is to have a mandatory allocation of 20% of our budget, either from FIF or SHA reimbursements towards the purchase of health products and technologies. Next slide. Then the other thing we do, which is also innovative, is weekly MPDSR meetings, not just when we have a mortality, but we also do have some that we do just to make sure we know where we are. And all our MPDSR meetings involve everybody, including private health facilities. Then we've been having a large collaboration in terms of the HPT team with the other healthcare workers to make sure that we are stocking up heat-stable carbetocin in all the facilities, as I had mentioned earlier. Then there's a recent purchase that has been made for NASG, which was supported by UNICEF, and these are expected to arrive by next week. Next slide. So some of the existing gaps that we are hoping to close in the upcoming weeks is the issue of pharmacovigilance. We have been doing a lot of pharmacovigilance trainings, nevertheless, but now we intend to focus it more on, of course, since we've introduced a new product to the facilities, we intend to now scale up our pharmacovigilance trainings to make sure that we are monitoring how the response is like and whether there are any reactions or events related to its usage, and also scale up the reporting and train people on how to use the platform. The next slide, please. So I would not talk about Nairobi County if I fail to mention the involvement of the private sector. So Nairobi is also known to be vibrant in terms of the private sector. So many of our patients or the population that we serve do also seek services in the private sector, and they are part and parcel of our system. So many of these facilities are highly involved in our MPDSR meetings. They are part and parcel of us. Actually, in our sub-county tomorrow, we're going to visit 2 of them. And we include them in all our CMEs, whether they are online or physical. However, we know that these facilities probably are not able to procure heat-stable carbetocin for themselves because of the high cost. And like us, who are in the public facilities who are able to buy it at a low cost of 95 shillings, most of these facilities are not able, probably some of them, to buy it at the 2,700 market rate. So what we are doing, of course, is to scale up the referral processes and linkages to ensure that the patients that they serve, some of them who cannot be able to afford the cost, are able to access heat-stable carbetocin at the public facilities at no cost. So we do this through our EOC, the Emergency Operations Center, which started during the NMS and has been taken up very well by the Nairobi County. And EOC offers free ambulance services to referring patients to public hospitals at no cost. And of course, it has a larger focus on maternal care. So also we do also include healthcare workers who work in private facilities in our trainings. And then all our supervisions, both by the county and the sub-county, are done also for the private facilities. We don't exclude them. And also in the mentorship and the CMEs that I had mentioned. Next slide. So on to the innovations, some of the innovations that we are working on or that have made our service delivery better is the project called Prompts, which is being done under Jacaranda Health. And this is a digital health solution that sends SMS messages to pregnant mothers and postnatal mothers with gestation appropriate health education, clinic reminders, as well as have their mothers' voices be heard, and they're able to also send free texts with questions and complaints, and as well as compliments to the healthcare providers or the facilities whenever they want. Then we also do a lot of quality improvement projects, QI projects, which focus on the use of pathographs to monitor labor. And then we have recently been able to launch a number of blood collection, do I call them subunits? This is not my area, but yes, like Mbagathi now has started collection, and this is also helping us to avail blood and blood products in our facilities. Next slide. So what next steps are we planning to take now that we have started on this new journey? We intend to review data to monitor what changes we are experiencing in terms of key maternal health indicators on post-intervention. After we have started using heat-stable carbetocin, like to see where are we at, where are we heading, are we making changes, are we making an impact? The other thing also we intend to do is to monitor the consumption, because we are not able to tell right now its consumption for the next quarter, but I'm sure by the end of this quarter, we're going to be having that data and the pattern of use, because it's not available in KHIS. Then we would like to also start advocating for heat-stable carbetocin to be added in the KHIS report that we do for tracer products, and also monitor to see whether it's being correctly used at the facilities. Just 1 second. Yeah, 1 second. Sorry, there's a window that had appeared. Then continuous PV reporting and training, as I had mentioned earlier, and then assessing training gaps amongst the users so that we're able to see whether there's more training that needs to be done apart from what we have been doing. Next slide. Yes, thank you. And that's the end of my presentation. Over back to you, Dr. Wamai. Thank you.
Thank you so much, Dr. Josephine. I must commend the pharmacists of Nairobi County. Sometimes I think they push us more to do the webinars, and we've really appreciated the role that you've played in having uptake. I think we've noted your challenge. Dr. Nora is always telling us about the challenge of Nairobi County in terms of having a lot of your healthcare being delivered by the private facilities. So I think the powers that be, some are logged in here, are going to note that we need to see what we can do to have access in the private sector. So thank you so much for your beautiful presentation. And for sure, Nairobi must work. Thank you so much. So over to our next speaker, Dr. Ndaisi. She's a sub-county pharmacist in Kajiado North.
Thank you, Dr. Wamai. Good evening, everyone. I'm Dr. Ndaisi, Sub-County Pharmacist, Kajiado North. I'm going to take you through the life-saving innovations that Kajiado County has been able to start on. Next slide. So in KDHS 2022, Kajiado County recorded skilled birth attendance of 85%, with the first NC, with NC past four NC at 81%. So with this, it means that our mothers are coming to us for the skilled birth delivery. So it is our responsibility to make sure that we give them quality care. So with that, we came up with strategies for to improve, and one of the strategies was to strengthen the active management of third stage of labor. Also, we had a chance to now start thinking about the availability of quality uterotonics that we were using at the facilities, especially the cold chain challenges. This means that there was a probable cause or reason that our oxytocin was losing potency due to poor storage conditions. Next slide. So for our journey, we had implementation plans. So for phase 1, definitely now the county adopted the heat stable carbetocin use as aligned to the MOH guidance. So this entailed updating the standard treatment guidelines that were existing, also training our healthcare providers. And also now we had to sit down, quantify, and see how to procure the commodities. Next slide. Then for phase 2, we had rollout. This one, we targeted high volume facilities and far-flung facilities that were offering maternity services. For public facilities, we have 136 public facilities and a total of around 1,000 plus, all inclusive. So part of the rollout, we had on-job trainings and mentorships on the service delivery points. Next slide. So for phase 3, we had monitoring. This we did. We integrated the RAMCA supportive supervisions with the QCIs. We also included the quarterly data. We also had the quarterly data review meetings that were helping us now gauge where we were and how everything was moving, trying to check the cleanliness of the data before now like adopting it like our real data. Then in monitoring, we also had use. In addition, we have 60 nurse G that are within the Kajiado County facilities. We also managed to procure 10,740 ampoules of heat stable carbetocin, KEMSA at 95 shillings, meaning that at least by now all facilities have access to the commodity. Next slide. So what's the outcome? In 2023, Kajiado County reported 519 PPH cases with 11 deaths out of 17 deaths. The 11 deaths were due to PPH complications. In 2024, we had 437 PPH cases. We recorded 6 deaths out of 25 deaths. The 6th were due to PPH. And between January and June this year, 2025, we had 230 PPH cases with 0 deaths out of the 9 maternal deaths. Next slide. So what are our next steps? One, we have to ensure that the commodity managers are also trained on the use of especially the heat stable carbetocin in our hospital setups to ensure proper supply chain management. This is to mean that unfortunately there was no specific training for the HPTs, and for other healthcare providers there's EBONC. So some of these things were just adopted into part of the training and people moved on. And we feel that also the commodity managers would really benefit when it comes to training, especially on the use. And this will also help in terms of procurement and also quantification. So the other thing that would help is if the calibrated reps are available at KEMSA, because currently, unfortunately, they are not available, neither in KEMSA nor MEDS, if I'm not wrong. Then the other step that would also make a big change you see some of the PPH cases we are having and also the deaths, we are reporting them also at private facilities. So if only these private facilities could also benefit from the subsidized prices of the commodities, this will also be an added advantage, because at the end of the day, we are aiming to save that mother, regardless of where she went to seek service. And then we also encourage continuous PV surveillance. At the moment, we have not gotten any reports. We don't have any PV reports. And then the other step is to include the heat-stable capitosin and also the calibrated drips. Like my previous presenters also noted, we need to do a follow-up and maybe also try and find out the use. You know, you can always query a use once you like sit down with a report. For example, if you see that you have a number of deliveries that are less than number of maybe the heat-stable capitusins that have been used, definitely there we will have to, you know, dig deep, because it's a single-use commodity, like you don't repeat it. And then also we need to monitor the impact of the current innovations to maternal PPH mortalities. We need to like also evaluate and find out whatever we are doing now, what can we increase, or where do we need to strengthen so that we really reduce this maternal PPH mortalities. Next slide. Ashe Oleng means thank you in Maasai language, in Ma language. And a parting shot would be a saying by the WHO, where postpartum hemorrhage is the leading cause of maternal mortality, yet most deaths are preventable with timely and effective interventions. This is where we all come in. Thank you very much.
Thank you so much, Dr. Ndaisi. It's you know, it's very heartwarming to see that you know, the pharmacists are helping us to actually understand some of the data, that you're able to actually help us interpret the data, and your perception is also different from ours. So I just wanted to comment about your data on the PPH cases in your sub-county, is that most people, you're going to find PPH cases will go up because of the detection using the calibrated drip. But you should also notice that then the deaths should go down, because now you've introduced a product that is actually, you know, preventing. I see a lot of questions on when do you use heat-stable cabetosin. Heat-stable cabetosin is used for the prevention of postpartum hemorrhage, which is what us guys now in the world will call Amstel. And then in case a patient proceeds and gets postpartum, you know, hemorrhage, then after that, we have protocols which now have other uterotonics like oxytocin and misoprostol that are now used in terms of treating a mother who develops postpartum hemorrhage. So thank you so much for all your presentations. I think we can clap for them. In the meantime, please drop any of your questions in the Q&A. And as I wait for your questions in the Q&A, I'm going to be asking Mariana Mutuiri. We did have some of the counties comment about faith-based facilities, and some of the private facilities are the faith-based facilities. So I'd like Mariana Mutuiri from MEDS to comment. Mariana is a global health policy advocate. She's also a PPH champion, and she's in charge of Access Partnerships at Access Partnerships Project Lead at MEDS. Mariana, I hope you're online. Hezron, have you found her?
Not really. Maybe if she can just raise her hand.
Mariana, please raise your hand, because I would like you to. Okay. Okay.
I see Mercy has raised her hand. I don't know if it's the
Okay,
same
just
person.
let's Okay, maybe just let her talk.
She's the one. Yeah.
Okay.
She's the one.
Okay,
Okay, fine. Okay.
Right. She can unmute. I think it's okay now. Mercy, you can unmute.
Yeah, so thank you very much. Good evening, colleague.
Mariana, your
I lead
internet.
Access Partnership. I'm also a people. Can you hear me?
Yes, but your internet is a bit shaky. Maybe just get a good position. Thank you.
Oh, okay. So good evening, colleagues. Please, Hezron, confirm you can hear me.
It's okay.
Awesome. Yeah, so my name is Mariana.
Sorry, we are losing you again.
Partnerships, so a PPH advocate for improved PPH. Hear me? Hezron, can you hear me?
We are losing you. I think there's still an issue with the network. Maybe we can try moving to a better position.
Okay. Let me try. Please confirm you can hear me now.
Yes, now it's much better.
Is it awesome? Yeah, so like I mentioned, good evening, colleagues. My name is Mariana Mutiri, a global health advocate and a PPH champion for Kenya, a pioneer in the introduction of the HSC calibrated drips and the great innovations around reduction of preventable deaths due to postpartum hemorrhage. So I would like to just give us some insights around the work that you've done together with Ruth Wamae and the Ampli PPH program. So for MEDS, we were able to introduce the product in our catalog, and we are currently availing it to all our FBOs and some government facilities and county governments at 92 shillings. So in case there are any challenges around access, you can feel free to reach out to me and we'll be able to ensure that the product is available. I'm glad that Dr. Josephine, we've had a previous conversation with them and also in policy shaping. So I think that's what I can say. The other thing that I would like to say is that you're implementing a Gates funded project, and these innovative products are part of the commodities that we are supplying to around 100 faith-based facilities affiliated to the Christian Health Association of Kenya. But we are not limiting availability of these products to faith-based facilities alone. They can also be available to the public health facilities. Thank you, and back to you, Hezron.
Okay, thank you so much, Mariana. And we are excited the fact that you've been able to actually have the product at MEDS, and we are going to be looking forward and also just watching how you do the introduction in the faith-based facilities, because we know you're also delivering a lot of healthcare in the country. So we look forward to collaborating and also supporting you with the introduction. So there's quite a number of questions. Hezron, I'll just comment on this one because it's about presentations for pharmacists. I noticed some of the pharmacists would also like to just be told about the pharmacokinetics and how the drug works, other beyond issues of procurement, so we can plan that. And then Kibonge, I'd like you to just do for me the Q&A as we tackle some of the questions in the chat.
Thank you, Dr. Amai. There's a question about pre-feed now that the reduction of the price of this stable carbetocin, comparing it with the price in the private sector. And I think I'll ask Dr. Josephine whether she has seen any cases of theft within Nairobi County because of that variance in price. Dr. Josephine?
Yes, I'm here. Thank you for that question. I think I was just responding to it on the Q&A. But so far, we have not seen that yet. But in Nairobi County, we monitor all our products through daily returns. We expect facilities to give us daily stock returns of everything they utilize. And I think that way we'd be able to know if there's any leakage. But to the best of my knowledge, not yet. Thank you.
Thank you. The question for Dr. Chomba about Makueni. Now that you're using carbetocin, have you seen a reduction in number of blood transfusion cases? And if there's a reduction by approximately what percentage?
Thank you, Kibonge, for the question. Just before I answer my question, allow me to just add the previous question. So, heat stable carbetocin, you get 1 ampule immediately after birth, after delivery, and you can easily match the number of ampules consumed and the number of births. So you can easily detect whether there's any foul play, whether they're by comparing the consumption data and the patient data. So on blood transfusion, as it was elaborated by Dr. Amai, since you're now using liberated drips, you're able to detect PPH early and you're able to take appropriate action early. We are yet to do the analysis on the blood transfusion and see whether there's been a reduction or an increase in blood transfusion. It's one of the things that we need to do. We want to tailor it as a study, and maybe at a later date we can present that. But the fact that you are able to detect PPH early and take interventions early, then you're able to take appropriate actions. There was some talk that the blood transfusion cases are actually going up, but we are yet to do it scientifically and try the two and see whether there's any correlation. So I cannot give a definitive answer on that, but it's something that we are working on, and we will provide the data once it's available. Thank you.
Thank you, Dr. Chomba. To Dr. Daisy, there's a question not specific to Kajiado, but the question is how the introduction of oxytocin has affected the uptake of oxytocin. Maybe you can mention whether you have seen any, either less uptake in terms of uptake of oxytocin. Dr. Daisy.
Thank you, Kibonge, for the question. I think it's important to understand that carbetocin is not coming to replace oxytocin. Oxytocin still has a huge place in management of PPH. So to answer your question, nothing much has really affected the consumption of oxytocin. As per definitely what I have observed in my county, because we still have patients who cannot be given carbetocin, who are contraindicated in the use of carbetocin. So most of the time in our setups, the priority is given to the mothers with the risk factors that are likely to bring about PPH. So I've not seen much of a substitute in the two. Thank you.
Thank you, Dr. Daisy. Michael, I can go then. There's a question about why drastic reduction of the price and whether it's sustained. Mike, would you want to answer that?
Yes. So there was a tripartite agreement between WHO, MSD for mothers, and Ferring. I believe this product has been there for quite some time, for many years in high-income countries, but it was not accessible in our environment. So because of its value, so there was a tripartite agreement between the World Health Organization, MSD for mothers, and Ferring Pharmaceutical, where MSD for mothers was to support a clinical trial that was to test whether heat-stable carbetocin is inferior to oxytocin. That is the champion trial, which happened in 2018, and Kenya was part of that trial. So that result came out that heat-stable carbetocin is not inferior to oxytocin. So WHO in that agreement proceeded to include HSC in the guidelines, that is the WHO guidelines. That was in 2018. And then in 2019, it was included in the WHO essential medicines list. And to ensure market access, Ferring Pharmaceutical has that commitment to avail it at an access price. And I know Jalango is here, and maybe she can add on that. Yeah.
Thank you, Mike. The other question that I see is how then this heat-stable carbetocin can be more accessible in the private sector in terms of the pricing. Dr. I want to put you on the spot because I know you are an advocate and you have a passion to equitable access. I want to hear from your advocacy side how you see more access also within the private sector, so that each mother can access this, facilities they deliver in any part of the country. Dr. Wamai?
Kibonge, it's a hard spot to put me in, and I'm going to make sure I put Jalango in the same spot. But our message for us is that we would like all mothers to have access to the product, because I think it doesn't matter where a mother delivers, whether she delivers in the public sector, in the private sector, in a faith-based institution. I think for us, what we would like to see is that we have been able to save mothers' lives. So I think our initial, and Jalango will be commenting on that, is that the initial discussion of the access price, I think, had left out the private sector. But I think with a request maybe from the government, this is a it's a request that can be reconsidered, So I think, Ms. Jalango, I'd like you to comment about that. And I think also there's a lot of query on how long is the access price going to be sustained. I'm seeing that coming up a lot in the chat. I'd like you to comment about that. Yeah.
Okay. Thank you very much, Ruth, and Ampli team, and also our presenters. My name is Atieno Jalango, Project Coordinator, heat-stable carbetocin for Project Family Safe Birth, an initiative of Ferring Pharmaceutical. Now, we come into the public sector to provide heat-stable carbetocin at an access price, and this commitment from Ferring has no end date. So this is a long-term commitment. So you are going to have a heat-stable carbetocin to the public sector of low and lower middle income countries. And Ferring has actually made certain steps to ensure that we can be able to supply the public sector by enlarging our capacity to manufacture heat-stable carbetocin in India through sterile gene by tech transfer, and also at our factory, having a dedicated line at our factory in Zhongshan in China. So in total is over 21 million ampules capacity, which we have not even been able to reach so far per year. And so we have really put ourselves in a position to be able to supply the public market. Then our commitment to the access price continues and will continue for the unforeseeable future. And in this regard, we have the IDA as our global logistics partner, and they will be the ones. They continue to be the ones who pick up the medicine from us and then distribute to the different countries. And we also have other players as well coming in, like Axmed. So for heat-stable carbetocin, essentially, if we look at the WHO guidelines, each and every mother who delivers should have heat-stable carbetocin for prevention in a setup where its price is equivalent to those of quality uterotonics, and the access price has made that a reality. So any mother who delivers in a hospital, so long as there is no contraindication, we should use heat-stable carbetocin to prevent PPH. And in the case that PPH occurs, then we use oxytocin. And of course, remember, heat-stable carbetocin is contraindicated for augmentation or induction of labor. So don't use it for augmentation or induction of labor. It should not be used under any circumstances before the baby or all babies are born. So you must ensure, if somebody is using heat-stable carbetocin, they check that there is no baby in the uterus. So no babies, then once the babies are all out, then you can give heat-stable carbetocin, and the dose is 100 micrograms, which is 1 ampule. That is the dose that is given in third stage of labor, what's called active management of third stage of labor, to prevent PPH. Should PPH occur, then you go to what is called the emotive bundle. So back to you, Ruth. Thank you.
Thank you so much, Jalango. Jalango is from the project Family Safe Birth, and she's been very key in helping with the negotiations and the introduction of heat-stable carbetocin. I think we need to plan. Maybe, Jalango, you could share also some materials that Hezron can share with his PSK members in terms of how the drug is used, or posters, something they can read before we're able to do a CME on proper clinical use and management of PPH. So that would be really appreciated. But thank you so much, and thank you so much also for joining. Yes.
Thank you.
I think in the interest of time, there's a lot of questions. I think we'll go through them and then maybe also plan another engagement with the PSK members as we continue. And Jalango, you did mention about very, very key is that people have to remember about the pharmacovigilance. And in case of any issue you have, please let us know. We can forward to her. Yeah, as we scale up the use of the drug. So Michael, I hope you're still connected.
Yes, I am.
Yes, yes. So thank you. And it's 6 minutes past 8. Please, I'm giving you 2 to 3 minutes to help us to close today's webinar.
Yeah, so thank you very much, colleagues, for the great work that you're doing in terms of saving our mothers. We know this is a collaborative effort, and we know that you play a critical role in terms of ensuring that our health facilities have access to quality assured medicines. So just like I mentioned, reduction of maternal mortality and morbidity is really a very huge task, and it's not easy. So when we get a solution that is making us make progress towards achieving the goal that we want to really achieve, I think it's really an opportunity to embrace it and run with it. We really appreciate the government of Kenya and the ministry for the great leadership that they've offered, especially in the national adoption of PPH innovations. It's really the focus globally because all stakeholders have said that enough is enough. We cannot continue having our mothers die, and the leading killer has been PPH. So I would encourage you to really take up this innovation. A lot of advocacy is required, engagement of the leadership, so that they can be able to understand. Sometimes we speak to ourselves and complain a lot, but if we reach out to the decision makers, to the senior most, from the governor to the CECs, we need to explain to them in a language that they can understand the value of some of these innovations. And just like we've heard from Kajiado, from Makueni, Kiambu County, which is also one of the counties that has procured the biggest quantities of its stable carbetocin, has been celebrating in the recent times in terms of reduction of maternal morbidity and mortality. And we know these stories can be replicated in all the counties in Kenya. It doesn't matter where you are, so please advocate. In case you need any support in terms of how to advocate, we are here to support you and we'll collaborate. These wins are not for a project or for an organization. They're really women of Kenya, and we believe we will make a huge difference and will be counted as people who dedicated their time, their energies to save our mothers. So thank you very much, and back to you.
Okay, thank you, Michael. Thank you so much to all our attendees tonight, all our speakers and my co-moderators. Thank you so much for being here tonight and for actually, I mean, it's not just tonight. I think through our journey since we started in 2022, everyone who is here has been actually a partner and has supported us through this journey, and everyone is actually playing their role. And we hope that we are going to see an improvement. A lot of people have actually commented about us monitoring the effect of this drug, and we hope we're going to have a good story to tell about the lives that have been saved. So we were in someone else's house tonight as Ampli. Thank you so much, PSK. And Hezron, I'll be handing it back to you in case you have any housekeeping issues. But thank you, and we've enjoyed our evening today at PSK. Thank you so much for hosting us, and we look forward to continuous collaboration. Thank you so much.
All right, thank you so much, Dr. Ruth, for the wonderful moderation and also for the speakers. Thank you so much for sharing the insights on the good work that you're doing. So as we close up the session, I'd just like to remind everyone, if you can subscribe to the event on the PPB portal so that we can be able to share with you the CPD points on time. And then the other announcement is about the upcoming webinar on evaluation of abdominal pain, the basics. And this is going to be hosted on Knowledge Lab. So we'll be sharing this on the WhatsApp platforms and other communication channels. So ensure that you be on the lookout for that so that you can be able to attend. And then finally, just a reminder for all the events that we've had at PSK, ensure that you subscribe to them so that you can send you the CPD points. Remember, the two of them are tied. The sooner you're able to subscribe, the sooner we're able to get points from PPB and share them with you. So once again, thank you for joining us, and for sponsor, Ferring Pharmaceuticals and the other partners, thank you so much. This is an engagement that started during the conference, and we'll be continuing more so that at least we're able to share more insights. At this point, I'd like to end the session, and we look forward to seeing you once again. Thank you.